Good afternoon. It is noon, so we're going to go ahead and begin. And I know people are still coming in, but they can continue to join us. Thank you so much for joining us today. We won't be doing a typical introduction as we normally do in our lectures, but we want to give as much time to this amazing panel as we can. You can see their biographies and their wealth of experience through our website. And also just to let you know that the Q&A box is open and you can ask questions throughout, but questions for the panel will be answered at the end. I do, however, want to take a moment to set the stage for this conversation that we are going to journey through for the next hour together. At the Fairbanks Center for Medical Ethics, we want to contribute meaningfully to the conversations that are happening in the world of clinical ethics. COVID-19 has brought to light what has been hidden to some, but so obvious to others, health disparities in the minoritized community. In order to contribute, in August, we hosted 2 lectures about Black lives and health justice, long lessons from a long civil rights movement, where we learned about the history of health inequities. In addition, our lecture in October focused on discussing death and dying with African Americans. We learned history and we learned tips. And then in December, the death of Dr. Susan Moore died of complications from COVID. And when she died, before she died, she privately and then publicly raised her voice and her own frustrations and her fears about our flounderings and our failures on how she was being treated at our own IU Health North facility. So FCME wanted to contribute more to the conversations on healthcare bias and inequities, but it felt like we were done giving information. It was now time to provide opportunity for transformation. Now I know that I can't force you to be transformed. You listeners have to choose to do that. You must have a willing spirit though, because you've already chosen to be here. So maybe we're preaching to the choir, but if that is the case, then the choir needs to sing louder and bolder than we have ever sung before, because I know that I must change, and that we must change, and that our system must change. So I hope that you walk away from this talk with the courage to do something, to be transformed, and maybe find the courage to help others find their own courage to change. We have invited 6 amazing people to share their wisdom and challenge us today. 6 is a lot, we know that. We have an abundance today. And I want to say up front that not everyone is going to be able to answer every question. And I may have to cut some off because we have so many wonderful stories to tell. Because we could probably talk for an hour just on one question, but we cannot. So I will work to moderate this conversation, not to be disrespectful to anyone, but to be respectful to all. And so I'm going to ask, and I'll call each of them by name, for each person to say 2 to 3 sentences, no more than 30 seconds or so, to describe your place and your perspective in this issue of health inequities. So Dr. Treadwell, I'll invite you to start first.
Thank you. My interest in health inequities has been during my entire career, and recently things that have been very significant are, as was mentioned, the death of Dr. Susan Moore, some of the information that we have received about treatment of our residents. And so health inequities, I have an interest in trying to decrease those as much as possible to improve the physical and mental health of our community.
Thank you. Dr. Meagher.
Thank you so much. I am a trauma surgeon at Methodist Hospital, and I am a Hispanic woman. So my interest in health inequities really stems from experiencing unequal care for patients who experience trauma, and particularly those who experience violent injury. And so I have been very involved in inequity research, even from the time that I was a resident, recognizing that patients have unequal treatment based on many different things, not just their race, and recognizing that we really need to do better as a healthcare system to help those who fall through the cracks.
Thank you so much. Dr. Haywood.
Yeah, I think my role, so I primarily work on training future clinicians and help with onboarding new practitioners. And I think my goals are around helping people check colorblind policies, check colorblind communication strategies, colorblind success initiatives, and then also to help people reflect upon and focus on themselves rather than others. I find that often when we have training and other initiatives, everyone's often like, oh, this would be so much better for my patients or my students or others. And I think the work really starts within and development of leaders and development of people who have voice and a seat at the table.
Thank you. Dr. Oruche.
Thank you. My life's work has been around mental health services, research, and education. And as I reflect on where my passion in terms of commitment to health disparities comes from, it's been from my work in our safety net hospital health system here in town. So lots of lessons and observations from working with my patients themselves and the different challenges that they present with, but also having incredible mentors who were themselves health professionals and modeled how to address the whole person for best outcome.
Thank you. Dr. Pettie.
Thank you. So I'm an emergency medicine physician. I practice at IU Health Methodist, and my interest in this area really started from the educational viewpoint of watching learners and watching how some of them interact with patients, better than others. I got very interested in communication and empathy, and therefore that kind of naturally led into interest in bias, specifically more of the personal and implicit bias. And I started studying that. And then really in the last year, because of all the events that we've already discussed, I started to educate myself on structural bias and structural racism specifically. And really, it's very, I don't know, I have learned a lot in the last year after kind of devoting time. And so I'm just excited to be part of this wonderful panel. So thank you.
Great, thank you. And Reverend Taylor, last but not least. William, you're still muted. I'm so sorry.
So I just said I thank you. Like my colleagues, I have been on the journey as a pastor, as a clinical chaplain, and the whole effort of diversity, bias has been a part of my prophetic tradition as a minister. And certainly within the clinical setting, I see it every day. We can't see what we don't acknowledge. And so the opportunity to begin to wear glasses so that we can see from a different perspective and hear narratives and give people an opportunity to open up, to share those narratives so that our treatment, our care is not one-sided, but it's really having a deep down or deep dive into understanding human beings, human lives, and even the unspoken and how that can have an impact on individuals. And so I see myself as an individual who lends voice or empowers others to speak their voice in such a way that they can be heard.
Thank you so much. So we know that words matter, and we want to make sure that we have an understanding of what we mean when we use certain words. So I know this, Dr. Treadwell, you could probably give an entire lecture on this, but in a couple of minutes, can you just tell us a little bit about what is personal bias? Where does it come from, and how does it affect, and what effect does personal bias have?
Personal bias is based on, for each individual, that you come to, so I come to this panel with a lifetime of different experiences, and that gives me a certain perspective about what happens and what I see. And I think Reverend Taylor mentioned that you have certain glasses on about what you experience and what you think. And some we teach medical students about a certain a group of symptoms. We want them to be able to recognize a heart attack. So there are certain symptoms that we want them to think about and then be able to make that diagnosis and care for a patient. The problem is that sometimes the personal bias and stereotypes come into that that actually affect what care that the patient will have. A short story about there were symptoms given, a list of symptoms given to cardiologists, and it was a conference, a national conference for cardiologists, and the symptoms were the same, but if they put up a picture of a white male, an African-American male, a white woman, or an African-American woman, the diagnoses that were made were different. And so that's a bias. That's a bias that affects how the patient is treated. I have my own biases about what I think as a patient will come in the room. What I have to work at on a daily basis is to try to avoid allowing those biases to cloud my vision so that I am able to make the best decisions for the patient that I see.
Thank you so much. Dr. Meagher, is there a different or an additional perspective that we can think of when we think what is personal bias?
I think that one of the main things is that a lot of people want to say that they're unbiased, and you can't be. Everybody has biases, just like Dr. Treadwell was saying. You're coming at this based on your own experiences. My experience as a trauma surgeon will be different than someone's experiences as a pediatrician or someone else's experiences as a dermatologist. And so similarly, experiences of nursing, social work, case management, everybody has a different lens on things. And what we have to do is recognize those biases, acknowledge them, and then allow that we try to make decisions despite those biases. So when we are evaluating patients or talking with families, trying not to be unbiased, but trying to take that into account and then consider where that patient is coming from, because the patient will also have biases. And so it's working together in a thoughtful manner to accommodate the biases rather than trying to be unbiased. And I think that's really one of the biggest lessons to take away from this. A lot of what we do in medicine leads us to having biases. It's a way that we learn how to diagnose patients.
Right.
But it's not, we can't put the blinders on and exclude all other things.
Right, thank you. Dr. Haywood, I want to give you a chance to jump in here. And then after you talk a little bit about personal bias, could you help us understand structural bias?
Yeah, for sure. So I would say personal bias is a very efficient way to operate. So we teach people that you have this automatic response system and this deliberate system. So we're trained throughout all health professions to develop quick responses. And I'm sure Dr. Pettie could speak to that, but it's like, okay, what's your plan? We have a few minutes to get this person in and out. And the danger of it, and I sort of use a tangential personal example. It's really hard for me to misremember that Pluto is no longer considered a planet, right? So when I think about bias, if every time you present a patient case of a Black person, you're always describing them as unemployed or having certain diseases, that automatic response is going to trigger because that's the most efficient way of delivering healthcare. And in fact, when you're trying to get patients in and out, or when you're working in a lab, or even answering a board style exam, your default is to trigger and talk about the things that are inherently learned. And the structural bias really speaks to the way we think about power policy in relation to our engagement with our audiences. And often, what we attempt to do is make things equal without acknowledging the inequities that exist within that idea of equality, right? So like equity is something that differs from equality, and it means recognizing specific challenges that have contributed to a population's distrust of the system or inability to access certain things. So we often make policies with the lens towards centering the majority because we don't want to offend them. And some may call that the idea of centering whiteness or centering the majority. You may argue that's where like the whole concept of all lives matter comes, because people don't see themselves reflected in that statement. And therefore can't separate out an inequity for one population from another. So policies are sometimes structurally inequitable through implicit and explicit bias. And often it's rooted in this idea of not wanting to offend one group over the other or trying to make things equal.
Yeah, thank you. Policies, we think policies are so black and white, and yet there cannot be. Dr. Pettie, are you able to kind of help us think also about structural bias?
Yes, I think, like I mentioned earlier, this is something that has definitely, I've understood more and more over this last year. And the way that's easiest for me to think about this is, we've talked about, several of us have used the word lens, we come at this from a different lens, and that's our personal bias. But imagine, stacking up a bunch of individual lenses all together. And that's how these kind of institutional policies are made. So structural bias is more like group bias, and it's large group bias to the point where it's institutional. And so, for example, in the educational world, you look at different kind of admission practices, and whether that's undergrad, medical school, whatever it is. And there's emphasis on test scores because the people that made the policies were like, yeah, you need to do great on testing. And none of them had that lens of, well, wait, this is biased and automatically is going to favor, a white population. Or maybe they put emphasis on alumni admissions, which again, just perpetuates the gap that has already existed. And so that's the danger of, if you have a lot of people with a lot of similar experiences and similar lenses that are all, stacking them on top of each other, that's what happens. And so that's kind of how I think about structural bias.
Super, thank you. Thank you, that's helpful. I know what's helpful to me is always to hear stories. I'm a storyteller and a story listener. So Reverend Taylor, can you give us a story or an example of from your own world and own personal experience of maybe either a personal or a structural bias issue when it comes at play?
Myself, I would like to say as well that when we speak about structural bias, we also want to include media. We need to include religious speech. We need to include every form of communication that exists in our society that has a lens by which it either elevates one culture and demonizes another. And I think that's so prevalent as we see media, as it communicates so much. I'm going to be mindful of a situation where I was actually a chaplain on call in an emergency situation, which there was, and we were told before the patient came into the hospital that this was a gunshot wound. The person was a victim of street violence, gang violence. And this was the conversation in the ED. And so when the individual came in, sure enough, the person was a GSW There was a lot of conversation, even from the police officers, that we know this zip code, lots of gang violence takes place over there. And a lot of names were just given about the humanity of the patient who was lying on the gurney. And what was surprising to me, but not too surprising, is to hear the comments from nursing and to hear comments from some of the physicians talking about this individual, a human being, a human life. So there's a narrative that's already assumed about the patient coming into the ED, because the narrative is this person is in a certain geographical location in the city of Indianapolis. I got an opportunity to meet that young man, and the narrative was all wrong. This young man indeed was shot in his community. It was a stray bullet that happened to capture him. Yes, indeed, the officers were counting $2,500 in his pocket, making the assumption that he had robbed someone. In fact, what had happened is that he sold his moped before all of this happened. A family man of 5 children with one on the way. If you were to meet that individual, have a conversation with the individual, the narrative changes instead of the narrative being projected upon the individual. And so, was that deconstructed? I have no idea. But for me, getting to know that patient and his family, it certainly softened me to the reality that we make gross assumptions about individuals because of their color, because of where they live in the community. And oftentimes, structurally, we're speaking about individuals who work in healthcare, not all, can make those same assumptions about the care that we provide for our patients and families.
Thank you so much, William, for that story. I have so many questions I want to ask you about that story. And so we'll more time conversations another time. Or there's always hoping for more. Dr. Oruche, I'm so sorry. Dr. Oruche, sorry, I'm so sorry. Can you share us a story from your experience about structural or personal bias?
I don't know that I can think of a story right away. What comes to mind is, so for example, with structural bias, and I'm glad we're talking about this because I had someone ask me, what is structural bias about a year ago. So a really good example, I think, from healthcare is how we have, at least in outpatient settings, we see patients only from 8 till 5. Well, there's some people for whom that may not work, or should they show up anyway, may over time be at risk of losing their jobs because they have to continually take off work. I see that a lot in the parents of children who I see, children who have mental health issues, where we see the kids quite frequently, and the mom or the parent, mother, father, has to keep taking time off work. And over time, again, there's increased risk. They may get warning from their employers. The other situation is where we have this 15-minute rule. So in general, if you show up 15 minutes late to your appointment, you may not get seen. So these are the kinds of just 2 examples of what we have in place in healthcare. And the question we have to be asking ourselves is, does it have to be that way? So for some people it works, for some people it does not work. So if you can say you have to take multiple buses to get to the appointment and the bus was late for whatever reason, or your ride didn't show up, well, you're not gonna get there 15 minutes. So for me personally, over time, I have learned to say to the patient, I'm happy to see you if you will wait until I finish with this current patient. In some situations, increasingly, the clinic where I work, for example, they now have Saturday clinics, or they have evening clinics to make sure that we can reach all of our patients and meet their needs and remove some of the structures or policies that we have put in place, but that may not be working for everyone.
Thank you. So when the six of us got together a couple of months or about a month ago, we talked about things that you all are hearing and from your colleagues. And one of them is, what if I make a mistake when I try to do something culturally appropriate? And I just did. I worked really hard and I wrote down Dr. Oruche's name. I have it pronounced here. She typed it out for me. We practiced a little bit and I still messed up. So how do we, that's vulnerable, what do we do when we mess up? Because sometimes we're afraid to try. And so how do we get bold enough to try, but then what do we do when we mess up? So Dr. Haywood, I see you're nodding. So can you help us think through that?
Yeah, I think it's okay to mess up. And in fact, there's a test you may want to Google called the Stroop test. And it's a basic test where you try to like name the colors, but you see text that describes another color. And people often struggle with that test. And what researchers in bias have done is they've used that test to run parallels to this idea of not wanting to say the wrong word. So when you think about Black, a person who's not Black may say, what do I say? Do I say African-American? Do I say Black? Do I say people of color? And that process very much mimics the idea of the Stroop test. And it's been found that clinicians and researchers are actually less productive when they're so focused on not messing up. And often people in the majority are silent in the room because they don't want to say the wrong thing, which totally goes against the idea of cultivating inclusivity, right? When we have uncomfortable conversations, the idea is that we all grow when we all make mistakes. So that really taps into the literature of a growth mindset. And I think part of it is recognizing the mistake you made, acknowledging, investigating where that's come from, and then offering yourself some loving kindness, saying it's okay. And then focus on building relationships that are proximate to that. So even after this panel, you can continue to try to work on saying that name because you may continue to interact with folks of diverse backgrounds who have names that are not typical for you to pronounce. And I think that's part of it is just having this mindset that we don't always have to have the right answer. And that extends to culture, just like medicine. When you come up with a differential, you want to have multiple options. You want to think through best possible situations. And we're all just taking the best guess possible. So there's a certain vulnerability that is valued, I think, when it comes to building cultural competence.
Super, thank you so much. I want to think about now health and equity. Oh, go ahead, Dr. Treadwell, you're ready.
I'm sorry. I wanted to mention, so saying the wrong thing and apologizing is totally different level than what I've had a resident tell me. She had a name that wasn't easy to pronounce. And the individuals would say to her, "What's your name?" And she would say it and say it as many times as she needed to, so someone could try to mimic what she said. But then it was like, "Well, where are you from?" And she's from Minnesota. And it's like, no, we mean, where are you from? So those are the individuals who are crossing the line, versus you having some trouble with a name and then saying, "I'm sorry, I practice, but I'm sorry." And I think before we started, the attendees won't know this, but you ask how to pronounce it. And so I think all of those are the right things to do. The wrong thing is to then sort of turn, I don't even want to say Dr. Oruche, turn her into, this is a problem because that's your name. That's the line that's crossed versus just not having trouble, pronouncing it.
Thank you. And no hard feelings, Robin. I really appreciate your practicing and wanting to make sure you pronounce it correctly. And you're doing a good job. So just keep practicing, okay?
I will, Dr. Oruche.
Very good. Excellent.
All right.
I think that
Robin, let me just jump in here. I think something that you just said, and Dr. Ruche, and I got it right. I want to say this, there's something to be said about getting out on the court and playing the game. Steph Curry is one of the greatest basketball players ever, but he didn't get that way overnight. And so we can either step out on the court of justice, step out on the court and embracing a community that is unlike ourselves so that we can begin to play the game and score together. So oftentimes we stay in the bleachers and we observe life rather than to get on the court and play life. And so I'm an advocate that even if you struggle with the name, it takes some humility to say, you know, I don't get it, but I want to get it. And so oftentimes we stay in the court or we stay in the bleachers, we look at life, we participate in life from that perspective and fail to realize that all of life is about being on the court and engaging in these difficult conversations. Because when you're talking about lives, it's not about preservation of emotions. It's about engaging another human being and calling that person brother or sister. I just want to.
No, thanks, William. Dr. Meagher, I wonder if you can think about or help us think about, like as a clinician, what if we make mistakes? I mean, we've already heard Dr. Haywood say and Dr. Treadwell say just to say you're sorry. Are there other ways that you can provide some coaching for us or words for us that if we, as clinicians, if we make mistakes?
I think that if you come at it from a place of humility and, you know, you can acknowledge, I'm very sorry, I'm struggling with this name, or, you know, tell me a little bit about yourself instead of where are you from, is a lot different. And it's about kind of what the context is that you're trying to speak to a patient about, you know, if it's a patient who had a gunshot wound who came in and you're speaking to them about a life that you may have no exposure to. You may have no understanding of what they have gone through in their lives that resulted in them being in that emergency room or in that hospital. I think that one of the kindest things you can do is just listen to the patient, listen to the person, allow them to speak and allow them to be themselves. And recognize that your bias is going to be there. One of the things that I have really been working on and trying to get rid of is the idea that we refer to patients as their diagnosis. This is a very easy step that can humanize patients. So don't refer to them as that gunshot wound in bed 15. Don't refer to them as the COPD or in bed 23. They're humans, they're patients with a diagnosis. And even something as simple as that affects our bias, what we're thinking about them. And yes, Dr. Oruche is saying patients are not their illness. And we have to, why not say that the lovely grandmother with 18 grandchildren who likes to garden over in bed 15, right? So instilling some humanity in our clinical care. I know we're all busy. I know we're all stressed in trying to get stuff through the EMR and trying to get orders in and trying to get to the next appointment or the next patient or what have you. But from a clinician standpoint, providing that amount of care, the other night, my patient came in and she was just beside herself. And she said, oh, it's my husband and my anniversary tomorrow. We've been together 14 years. And I think—
I'm going to give you 30 more seconds. Sorry.
Sorry, I'm so sorry. But I think that that's kind of a thing that now I remember that about that patient more than I can remember most other things I learned about her. And it helps.
Yeah. Dr. Pettit, I want to come back to you to something that you said that it's hard. We can't be afraid to make mistakes, and that's, I don't, especially as clinicians, we're all trained that we don't make mistakes. So where do we get? How do we become comfortable with the uncomfortable?
Practice. Talking to your colleagues and kind of creating a culture that it's okay to make a mistake. I think, when you see, and I maybe you're going to ask this question a little bit later, so I might be jumping ahead, but when you see somebody else do something that perhaps is not appropriate, not being afraid to say call them out. Although what I heard recently, one of my colleagues said is actually call them into a conversation about what just happened, and starting to create that culture and role model that for others around you. Because if I do that as an attending in the emergency department and I hear a comment that is, that gunshot wound in room whatever, like Dr. Meagher said, I can say out loud, you must be referring to Mr. So-and-so, or, whatever, and kind of just, you don't have to it doesn't have to be embarrassing. It can just be a quick corrective thing that is heard by everybody around you, so that when that happens the next time, perhaps a medical student that heard that does the same thing, and so you kind of just start this culture around open conversation, and it's okay to make mistakes. And it's not easy, it's still uncomfortable, but it gets better. You just really do get more comfortable being uncomfortable.
Thank you. Dr. Treadwell, are there ways that we can become aware, for those of us that have blinders on? William, we'll keep going with your glasses theme, but sometimes we have blinders. How can we take those blinders off and just become more aware about health inequities and biases?
I think one start is an old adage that you picture yourselves in the other person's shoes, that if you were laying on that gurney, how would you want individuals to respond to you and ask you about, or try to give you a chance to talk about it? And I think Dr. Meagher mentioned this earlier about open-ended questions. Tell me about yourself. That gives the patient a chance to tell you about what's going on, what they're worried about, and you a chance to get to know them in a more expansive way than just a single diagnosis.
Thank you so much. Dr. Haywood.
Yeah, I would add, just take small steps to build a counter narrative to the way that you think about the world. So think about some of your default media platforms, and then ask yourself what's completely opposite from that. And make a point once a week to just check your perspective. And that's part of sort of bias training, is building a counter narrative to the way you think. Because going with this idea of the rosy colored lenses, our world is shaped by these vicarious experiences. So you have to have something that just makes you stop and question things a little differently. And I was just going to add, also look for hashtags. There's a growing following of Black Med Twitter, or Med Twitter, and other hashtags that will give you examples of personal stories that people experience. And like Reverend Taylor and Dr. Pettit said, you have to practice, you have to be on the court, and you have to think about it as quality healthcare delivery. Taking the time to learn those little details and being there for a person ultimately breaks down barriers and makes you a better practitioner.
Thanks. So I'm going to ask Katie, or Dr. Pettit would like to have one quick comment about making mistakes.
Yes, I meant to add this earlier. I think that, in talking with patients and in talking with colleagues, if you approach a situation and they know that you're being open, you're listening, you're trying, you can make a mistake and they're not going to hold it against you because they realize what this situation is. So I think that it's really truly on how you present yourself and what your intention is, as opposed to using the right word. So I think sometimes we get way, way too hung up on the right word or the right exact thing to do in that moment, but it's really about openness and wanting to do better. And people see that, they feel that.
Thanks. I felt that from Dr. Oruche. So while we're talking about Dr. Oruche, are you able to provide us, are there examples that we can look at about health inequities that have been rectified? And what did it take to do that? And maybe using that as a lens to help us in the future.
Absolutely. So I mentioned earlier how at the primary care or community health center where I work, we now have a clinic on Saturdays where we provide care so that those who, for whatever reason, maybe because of work schedule, cannot come during the week, can come on weekends. I see many adolescents in my practice. I schedule the appointment for after school at 3:30 so that they don't miss classes, So those are the kinds of little things that one can do. I want to also add that our patients come with incredible wealth of knowledge and experiences that we should leverage. I am very intentional in saying to my patients at the very onset, we are here as a team. I will bring my professional knowledge, you will bring your lived experiences, and together we will, share in decision making. So please, activating your patients' voices, leveraging their wisdoms, I think is very, very critical, in moving us forward.
Thank you. So I'm aware of the fact that we have about 20 minutes to go in our talk, and I have seen some really great questions come in. I have a few more that I can ask, but I want to let our attendees ask them. So Dr. Helft, if I know you're on, if you could, I know you've been monitoring the questions, so if you want to go ahead and ask one of the questions that's on there, and then we'll.
Robin, there's one of the first questions. Can you hear me? One of the first questions that was asked is a really interesting question that I think would be appropriate for both for Katie and Ashley, and probably for William as well, about the sort of intersection of police presence and medical care. Those of you, because you have come from the trauma surgery and the ED world, how do you, this person in the question actually raises the issue of how much attention there's been to police interaction, police violence. I wondered if you can make some comments about how to make those distinctions and to be sure that the care does not overlap.
Dr. Pettie, as an emergency room doctor, I'll ask you to start, and then we can kind of move around the circle that Dr. Helft suggested.
Yeah, it's hard because there are situations where I'm very thankful for my security, in the emergency department. I will say that I can speak to where I practice, probably certainly best and probably just where I practice. We try very hard to only call, security and our police when we absolutely have to. We try verbal de-escalation, but there are certain circumstances where it is helpful to have them there. But we do talk about this and we debrief about this with our nurses, with our learners, anytime that they are involved for these reasons. Now, I will say it's just been in the last year that we've been more intentional about these kind of debrief sessions. So I would say I don't have a perfect answer on how to completely get rid of them in the caregiving process, but it's certainly something that we talk about and discuss and monitor and try to be intentional about when they're there and when they're not.
Thank you. Dr. Meagher is another perspective.
Thanks. I think that's a really great question. We have a number of issues regarding patients who are in custody or incarcerated. I think one of the things that frequently gets forgotten is that these patients are humans. And we need to take care of the patient before we take care of what crime may or may not have happened and what they may or may not have done. I frequently find that there is a lot of effort to get to question a person or to get them in custody before we've even addressed their physical ailments. And the really big thing is that healthcare workers have to stand up for patients. You have to be willing to say, now's not the time. This isn't appropriate. And that's hard. I struggle with it personally. It's hard to stand up to 2 or 3 large security or police folk. But their job. I'm trying to do my job. And I think that this is a great time to have these kinds of conversations. We have to treat patients who are in custody or incarcerated better. And we have to treat them, we don't know the story. We don't know what's going on, and we can't treat them based on what the hearsay is.
Super, thank you. Reverend Taylor, your perspective on this question. I'm gonna unmute yourself again.
I think we can all get a sense of the enormity of that question of intersectionality. I think one of the challenges that we as a healthcare community are needing to expand is our understanding of different cultures. So for example, if you have a family who comes in and there is a fetal demise, if there's a grandmother who has died, in some occasions you're going to get a loud outburst of emotions from families. The knee-jerk reactions that I have seen is that there's a tendency to call our police officers to literally contain the crowd. And rather than emoting and supporting the family, there's the effort to de-escalate one's own reactions to a family member. And so I see this repeatedly within healthcare, is that when we have families who gather in large mass or in mass, there is a tendency to evoke power in order to control. And is that the kind of message that we want to provide within a healthcare setting? Is it easy? No, it's not easy. But I think that in some cases, rather than to contact police, why don't we dispatch other individuals, perhaps chaplains, to help with the family, to quail some of the when I say quail, at least to contain some of the emotions that are going on, rather than from the perceptional bias that we're talking about, personal bias. Well, there's danger lurking. And then people have their own reactions and they're wanting the institution to respond quickly in order to take care of the situation. So it's an ongoing conversation that we all must wrestle with as we're looking at our diverse populations within healthcare.
Thank you, William. Dr. Health.
Robin, so there's another great question here about how to respond if you see, let's say, an incidence of what you might perceive as bias with a person of superior authority to yourself. How would you respond to that? I think that's a great question to ask Patricia Treadwell and Antwione Haywood, who I'm sure have experience with this question.
Absolutely experience with the question. And in pediatrics, certainly there's a situation where we're speaking with parents and we're interacting with parents. And so being able to focus on the child and what they have and interact with a parent who may be under very stressful circumstances. If their child is sick, then they're going to be pretty stressed. I know that personally. You're pretty stressed when your child is sick. I work at Forest Manor, which is community health center. So I'll go back to the question about rectifying issues, is to have a community health center that's in the community. Individuals can walk to the clinic. I had one parent who knew which day that I was usually there, would come and bring papers to sign. And so that helps to rectify it, to be in the neighborhood close, and where you don't have to depend on switching to two different buses to get there. And a number of times I've had patients who have walked to the clinic. And so that does help rectify the transportation issue. The other situation that the question was about is that in several years ago, I was in a clinic. There's no question that child abuse reporting, all the literature supports this, is there's an increase in child abuse reporting for marginalized patients, socioeconomic and racial, when there isn't, in fact, the amount of child abuse is not increased based on those two parameters. I was there. It was an older pediatrician who was a white male. There was a student who came in. The child had a fracture of one of the leg bones, which would normally mean it was something that we would report. And the white male physician said to the medical student, well, we don't have to report them because they live in Carmel. And so it's like, that is what happened to my eyes. I was like, and I didn't feel like then, certainly today I would have said something, but at the time I didn't feel like I could say, the literature doesn't support that. And so I think that we all have to start feeling more comfortable about bringing that up, because that was an inappropriate message to the student, inappropriate to the family, inappropriate to the student, that you make a judgment based on somebody's zip code.
Yeah, Dr. Haywood.
Yeah, I would just add, there's great literature on resiliency and this idea that people who have strong levels of optimism are more likely to accept the barriers to any situation and focus on solutions based on that. So as a person who never got into their first grad school choice, or had to travel halfway across the country to go to college or to get into different positions, I approach a lot of situations like that. And I had an interaction that Dr. Treadwell was present, where I had to present the new honor code, which is a project I'm co-chairing for the School of Medicine. And in some of my pre-conversations, there were lots of concerns around bringing diversity into the honor code, and a question of whether or not that should be a part of maybe a separate diversity statement. And I was very adamant about figuring out what was important to the dean and framing everything we did around that. So I rooted the honor code in our values, and then focused on some of the important goals for IU as an institution. So if you think about things that Fairbanks has talked about before, like the Monon Trail Project, there are specific targets around improving population health. And much like someone said at the beginning, you can't effectively diagnose a problem if you're not willing to name it. So we have to be willing to call out injustices of certain populations, and then talk about potential solutions. And that's how I really framed our work with the honor code. And that really develops from sort of intrinsic thoughts around optimism and resiliency. And I think as you work with people above you, it's important to stop and have that moment where you really think through, ultimately how you connect with that person in a way that resonates with them. And certainly, as a side note, there's literature that people best receive messages from people that they identify with. So having a person who identifies as Black and having another person interact with that person, the conversation may go better than having me as a Black male try to check a white male colleague on a topic, because there's a natural defensiveness that comes from that. So I think stepping away, and I think as Dr. Pettie put it, instead of calling people out, calling them in, and rooting in systems values allows you to have a more productive conversation and solution.
Paul, it looks like we have time for one more question. We have about 5 minutes left.
Yeah, so there's a nice question here about specifically at the healthcare system level, are there examples of networks or hospitals that are doing equity and community engagement work well? So could we hear of any success stories? Maybe Dr. Oruche would help us with that. She may be familiar with some. Dr. Treadwell may also be familiar.
I know at Eskenazi Health, particularly really across all of the community health centers, but the PECA clinic, there's definitely a strong connection between the leadership and the staff team and the community. It's really outstanding. So for example, for many years, but the whole COVID pandemic certainly elevated and scaled that up, is where we have all kinds of different arrays of services within one location. A really great example was, the food pantry that was scaled up so that, staff members alike, but also members of the community could access, whatever resources that they needed that way. One of the example was where community health workers, even through the COVID pandemic, when patients couldn't come into the clinic, will go out to the patient's home and continue to provide services. So, this idea of, health systems within communities should strive and reach out to the community members and have the community be part of, patient advisory board, or, just be part of the health system in terms of informing what services the community needs, how best to meet those needs is critically important. At the School of Nursing, where I work here at Indiana University, we surveyed just last year all of our incoming master's students, asking about cultural competencies. And one of the things, most common response from all of our students, there was over 135 of them, was they wanted to better understand, not just being in inpatient settings where they do clinical practice or outpatient settings, they wanted to be out into the community so that they can actually relate and interact with their patients and hear directly from them about what they need, about who they are, so that they can better serve them. And for that matter, wanted professionals from those communities to also come and be part of those who educate them within the academic setting. So can't say enough about this partnership with the community. We have to tap into their wisdom and lived experiences to help us to serve everybody.
In about 30 seconds, Dr. Treadwell, are you able to, or a minute, are you able to give or find some examples to share with us?
The example that I would share is that I work at the Comprehensive Sickle Cell Clinic at Riley, and within that clinic we have social work, we have had chaplain students, the providers, the nurses, and it ends up to be that we're able to provide for the patients and the families a number of different aspects that if it were just physicians, that we would not be able to do.
It takes a team, doesn't it, Dr. Treadwell?
Absolutely.
And an interdisciplinary team is what I also just heard you say. Well, we knew that this panel would be a wealth of knowledge, stories, wisdom. We knew that it would be a thing that we could do for all afternoon. We could just sit around the table and enjoy each other. And yet we must end. And so I know that conversations will want to continue. They need to continue. They should continue. And so we hope that you will find ways within IU Health and within the School of Medicine or the School of Nursing, wherever you might be located, to tap into some of those places, to lean in, to encourage others to lean into those conversations. We know some of you have been asking about some of the resources. We will send out some of them tomorrow, as some that Dr. Haywood mentioned and some that Dr. Pettie put up online. For those of you that attended, we will get those out to you. So to the panelists, I want to say my gratitude for sharing your stories, your experience and your time with us. And for those of you that attended, thank you, and continue to be encouraged to change and to lean in. So goodbye all until next month.